Good morning, good afternoon, good evening, colleagues and friends from the IOIS Federation across the globe. My name is Rosana Pelayo, Principal Investigator on Oncoimmunology at the Mexican Institute for Social Security in Mexico, and I will moderating our webinar today. We have more than 400 participants. Thank you all for joining us. Our special thanks goes to Thermo Scientific for supporting the production of the session and promoting international cooperation. It is my great pleasure to introduce our speaker today, Professor Wolf Hervé Fridman, who is Professor Emeritus of Immunology at the University Paris-Cité in Paris, France. He is MD PhD from the University of Paris, former professor of immunology at the Paris Descartes University Medical School, director of the Cordelier Research Center, and head of the immunology laboratory of Hospital Georges Pompidou in Paris. He's a global leader in the field of tumor immunology, with extraordinary contributions that have opened a way for novel strategies for prognosis and therapy. In this webinar, relevant findings on tumor microenvironment changing the paradigm of host cancer interactions will be presented. We will also learn that the immune contexture is the major prognostic factor for human cancers, and that tertiary lymphoid structures predict tumor response to immunotherapy. His papers have been cited over 20,000 times, and his H-index is over 100. Professor Fridman, thank you for taking the time to be with us. The floor is yours.
Thank you very much, Rosanna. I'm very glad to be here and to share with you this webinar. What I will, I'm trying to work on my presentation at the same time. You see it in full screen, right? So what I will do today is really to focus on how the anti-tumor immunity is being shaped in the tumor microenvironment. I will do it only on human data, illustrate with data from our lab and refer to others, of course. And because this has direct relevance to the new treatments and the new response to the novel immunotherapy treatments. So we all know that tumors now, it is well established to grow and to invade, have to interact with their microenvironment. And the tumor microenvironment is made of many different type of cells, of course, vessels, vascular and lymphatics, stroma, great part fibroblasts, and you can find all cells of the immune and inflammatory system, mast cells, neutrophils, myeloid cells, dendritic cells, all lymphocyte subtypes. What is clearly a feature of the tumor microenvironment is in many cases, it is organized. And you have cells in the center of the tumor, in the tumor core, in the invasive margin, and adjacent to the tumor. It is more and more now become evident that there are tertiary lymphoid structures that I will discuss during my talk today, which are sites, we believe, and I think there are good evidence for that, of generation of anti-tumor immunity. For a long time, the impact of the tumor microenvironment and immunity in general on the control of tumors, of cancers, has been neglected or even looked with very negatively. And there were, until there was the analysis in mouse by the group of Bob Schreiber, who really showed that mouse which are immunodeficient do develop cancers with no any other stimulus, and work in human, and we contributed with this work, and I will show you data from 2005 now with Jérôme Gallon, in which we studied about 1,000 colorectal cancers and at different stages, and the disease-free survival of these cancers, whatever the therapy was, usually they have surgery with or without chemotherapy, was completely dependent on their stage. Stage 1 and 2, which are local tumors, have a 20 to 30% recurrence rate, 30%, 40% when there are lymph node involvement, and of course metastatic diseases are all recurred and are not metastatic free. By analyzing various parameters, what we showed at that time is that the presence of one category of cells, memory T cells, CD3, CD5 row, both in the invasive margin and in the center of the tumor, was strongly associated with control of the cancer. For instance, even tumors at stage 3 with lymph node involvement with high invasion of infiltration of memory T cells did better than patients with stage 1 small tumors, which were not selected. And it was even the case for metastatic tumors. But maybe more importantly, in tumors which have lacking memory T cell infiltration, they behave as metastatic tumors. Even small tumors, you see, relapse in a few months when they don't have immune reaction. And this was the basis of the immune contexture we dared to write, you see, 15 years ago already, that the evaluation of the type, the density, and the location of the natural in situ immune reaction within distinct tumoral territories predicts clinical outcome better than the classical tumor extension, the T stage, the N stage, the metastatic stage of the cancer. At that time, we were not very popular with this saying. Now things have changed quite dramatically, also because, and I will come to it, the successes of immunotherapy. These data have been confirmed in many different tumors. And here you have a meta-analysis of the impact of high infiltration of CD8 memory T cells in various tumor types. You see that in green is a favorable impact with longer progression-free or overall survival. In red is a negative impact. And you see that in the vast majority of cases and in many different types of studies, when there is a strong infiltration of memory T cells in the invasive margin and in the center of the tumor, it is associated with a good prognosis. So there are other cells in the microenvironment and T cells. And in fact, T cells are not the major cells. The major cells are clearly in many different tumors, macrophages. In the center of the tumor and in the invasive margin. There are also B cells, and I will come back to them because they have been underlooked. There are polymorphonuclear cells, granulocytes, there are Th17 cells, etc. And they are present, each peak represents the quantity or density of cells at various levels in the center of the tumor and the invasive margin. They do impact differently the clinical outcome. In green is a positive impact, and as you can see here, particularly in the center of the tumor, all lymphocyte subsets are associated with good prognosis, including T follicular helper cells. B cells are also associated with good prognosis, colorectal cancer and many others. I will come back to it. Also in the invasive margin in the center of the tumors, whereas mostly inflammatory components, myeloid cells, Th17 cells, immature dendritic cells, distant granulocytes are associated with poor prognosis. So in view of this situation, which tells us that lymphocytes in the vast majority, and in great part, lymphocytes involved in adaptive immunity are associated with good prognosis. The question arises of where and how is a potential anti-tumor immunity shaped in the tumor microenvironment. And this brought us to the tertiary lymphoid structures, which are represented here. Tertiary lymphoid structures, which are found not only in cancers, they are found in many other situations. They are ectopic lymphoid organs, found where there is chronic inflammation, chronic infection, chronic graft rejection, but also there is inflammation and chronicity in cancer, adjacent to the tumor beds in cancer. They are composed of a T cell zone in which mature dendritic cells are associated in close contact with T cells. They are surrounded by high endothelial venules, which allow naive T and B cells to directly enter into the tertiary lymphoid structures, escaping the immunosuppressed and inflammatory milieu of the cancer, of the tumor, and they are composed of a B cell zone. So they have all the features to have both a T and B cell priming and activation. And we propose, and I will show you data in favor of that, that they are sites of generation of the anti-tumor immunity. For instance, what can be the argument? This is an analysis in non-small cell lung cancer, which has been done in the laboratory by Marie-Caroline Bunejean. As in many other cancers, high density of CD8 T cells in non-small cell lung cancer is associated with good prognosis as opposed to low density. However, if one takes the cases with high density of lymphoid of CD8 T cells and separates them in function of the presence of tertiary lymphoid structures, here mature dendritic cells and the TLS, you see that when there are tertiary lymphoid structures, CD8 T cells are always of good prognosis. Even the progression-free survival or the overall survival here is longer. But when there is no tertiary lymphoid structures, even with high densities of CD8 T cells, it is a poor prognosis, as if you would have low density of CD8 T cells. So showing it's not only the presence of the CD8 T cell, which is important, but the site and probably the way that they have been induced and activated. Not only are there T cells and TLS, there are also B cells, and this compares a lymph node to TLS and non-small cell lung cancer. You see that there is a germinal center in the mature TLS. There are follicular dendritic cells, CD23 positive, a network in the middle of the B cell zone. There's activation-induced deaminase. B cells do proliferate, T67 positive, they express BCL6 and not BCL2. And you can find plasma cells, and we'll come back to it, leaving the tertiary lymphoid structure. So when there are mature TLS, a full maturation of a B cell response can occur. And indeed, already in 2014, we noticed that if we took B cells from tumors with TLS and activate them with a polyclonal activator, we could find a series of antibodies, both IgG and IgA, reacting with tumor-associated antigens. In this case, was an analysis mostly of cancer testis antigens. So suggesting that they may produce antibodies, and if they do that in these B cell follicles, as the B cell follicles, as the T cells associated with good prognosis, the answer is yes. Both in early stage and in advanced stage non-small cell lung cancer, the presence of B cell follicles was strongly associated with better disease-specific survival in 2 cases, suggesting already almost 10 years ago that the B cells could be of favorable prognosis. However, including ourselves, we didn't pay too much attention to it, I must confess. In a review that we published a couple of years ago, we showed that we remembered that CD8 T cells are associated with good prognosis in many different cancer types. Tertiary lymphoid structures, this is also the case. In hepatocellular cancer, when they are distant, they are poor prognosis. But when they are close, they are good prognosis. Tregs are usually associated with poor prognosis. Macrophages, it depends, but and we know now that there are different types of macrophages, but when they are associated with immunosuppressive characteristics, they are always associated with poor prognosis. Not a word on B cells on this matter. Now I need to introduce another point which is important for the rest, and this is the novel immunotherapy directed against checkpoint blockade. And here you know it, of course, that when a T cell is activated, not to prevent its uncontrolled proliferation and activation, it expresses checkpoint molecules. Here the two which have been used mostly in immunotherapy, PD-1 and CTLA-4, which react with their ligands either on tumor cells or on antigen-presenting cells, and this induces exhaustion of the T cells. So coming with antibodies, either anti-PD-1 or anti-PD-L1 or anti-CTLA-4 to block, inhibit this interaction, reinvigorate this T cell. And this has been a major finding for immunotherapy that has led to the Nobel Prize that was awarded to Jim Allison and Tatsuko Honjo 4 years ago. And Tatsuko Honjo discovered PD-1. Jim Allison did all the analysis that allowed CTLA-4 to come into the therapeutics, but I always like to remember that CTLA-4 were discovered by Pierre Goldstein in 1987, analyzing genes expressed in cytotoxic lymphocytes, and that's why it's called CTLA-4, because it was the first gene decreased. But it is really Jim who did the full analysis of its role and its impact. So it has changed the treatment of many cancers, but not all. And I show you here what is called a pediloma, which are the different cancer types which patients respond to the PD-1, PD-L1 block. And it goes from blue to yellow, more and to less responders. And as you can see here, there are cancers who really almost 100% response. Hodgkin lymphoma, Merkel cell, squamous cell carcinoma, melanoma, that was a deadly disease, 60% response, renal cell cancer. But other cancers are quite resistant, and you have a lot of breast cancer, for instance, is still about 10–15% responders, low levels of response. Sarcoma, that I will discuss later, are also low levels. So it is important to understand immunologically, because this is an anti-T cell directed immunotherapy, what is associated with response and what is associated with resistance. And until a few years ago, everything was T cell centric. Response was associated to high tumor mutational burden, creating neoantigens, checkpoint expression, PD-L1 on tumor cells or infiltrating cells, high quantities of CD8 T cells, low circulating neutrophil lymphocyte ratio, gut microbiomes, etc. Resistance was a mirror. Lack of T cell infiltration, high quantities of Treg, expression of alternative checkpoint proteins, TIM3, LAX3, etc., which are now checked, presence of suppressive immunosuppressive cytokines, VEGF, TGF-beta, etc., and genetic mutations which resulted in immune desertic microenvironments. And the future directions were considered to be all directed to T cells. Not a word really on B cells and other cells. This changed a couple of years ago when 3 papers appeared in the same issue of Nature, in which one paper was our own work in sarcoma that I will discuss in one slide, and 2 papers in melanoma. We collaborated with Jean Wargo on one of the papers, and the paper by Johan Johnson in Sweden. What these papers showed is that B cells, to the surprise of everybody, including ourselves, were associated with response. And this has a strong implication. Let me take one slide to explain our work in soft tissue sarcoma. Soft tissue sarcoma, metastatic particularly, are resistant to all treatments, poorly responsive, if not at all, to immunotherapy, and they have low mutational rates. new classification of soft tissue sarcoma based on transcriptomic using a software that we had established called MCP Compa. And we classified them in 5 categories: 2 immune poor classes, sick A and B, 1 vascularity high class, 2 immune rich class, E being the richest class, and this is independent of the histology of the sarcoma. And in this rich class, we had signatures for all immune cells: T cells, CD8 T cells, cytotoxic cells, NK cells, B cells, myeloid cells, etc. So then we analyze all these different classes did impact overall survival. Does it have a prognostic value? And the answer is yes. Sick E is associated with longer survival, and this was an independent, it's a really immune contexture driven control of the evolution of the cancer. So we ask among these signatures, what are the signatures associated with longer survival? And to our surprise, it was not T cells or CD8 T cells. CD8 high or low is the same. B cell high or low. B cell high is associated with longer survival, B cell low with poorer survival. And this was independent of the CD8 signature. B cell high, CD8 high, prognosis, B cell low, CD8 high or low, poor prognosis. It was surprising to us, and it was also independent of PD-L1 expression, of CTLA-4 expression. Then we got access to a trial. Hussein Toby was the PI of this trial at MD Anderson, in which patients with soft tissue sarcoma were treated with anti-PD-1. And we applied our immune classification, and we asked the question, does it correlate with response rate? And it is very striking. As you can see here, immune poor classes, 0% response. Immune rich class, 50% response, which is metastatic soft tissue sarcoma, very impressive. And the other classes went. Looking for a correlate for sick E, we found that the presence of tertiary lymphoid structure was almost pathognomic of sick E. Sick E is 80% of them had tertiary lymphoid structures, sometimes several dozens of them, and we found 1 outside of sick E. So now we can use tertiary lymphoid structures to ask the question, is there a correlation between these, because this is pathognomic of the responder, and the response rate in various different cancers. So in collaboration with Antoine Italiano, Lucie van der Secke, and a group in Bordeaux, we analyzed retrospectively more than 500 patients which had been treated by PD-1 blockade, either anti-PD-1 or PD-L1. And we asked the question, is the response and the survival in this case is dependent on the presence of mature tertiary lymphoid structures? I show you only one cohort. This is the first cohort we analyzed, 328 metastatic patients, mostly lung cancer, but also soft tissue sarcoma, bladder, colorectal, head and neck, renal cell, breast, and many others. So this opens really to a general rule what I am discussing here. And what we found is, I will summarize in one slide, we detected a tertiary lymphoid structure either by H&E classical labeling, you see the germinal center here, or by CD3, CD20 labeling, and it was confirmed when necessary by the presence of a network of CD23 follicular dendritic cells inside the B cell zone, signing the presence of a germinal cell. So when we analyze the response rate, patients who had tumors with no tertiary lymphoid structures, very little level of response, 20%. Immature without a germinal center tertiary lymphoid structure, no change. Mature, 3 times more responders when there were mature tertiary lymphoid structures. And if we ask the question, how many patients are alive after 2 years, it's twice as many when there are tertiary lymphoid structures as compared to the one who have no tertiary lymphoid structures, and you can see the difference in progression-free and overall survival. So based on that, Antoine Italiano decided to make now a prospective trial. And so I think it is the first one that has been done worldwide, in which all patients with soft tissue sarcoma were selected on the presence of tertiary lymphoid structures. And only these patients were treated with anti-PD-1, and this was very recently published in Nature Medicine. So, as I told you, soft tissue sarcoma is a non-responder to checkpoint blockade. However, in this cohort, we had a response rate of 30%, stabilization of 33%, and these are metastatic patients, and only 33% had a progression disease. And maybe what is more important is that when there is a response or a stabilization, it does last. And therefore, the natural history of the cancer in this patient has been really changed, and it has helped, of course, quite a lot the patient. I think it should change the way soft tissue sarcoma and metastatic stage are treated. So now we have patients, all of them have TLS, and we can ask the question, what is associated to response? So we analyzed all genes in RNA-seq, and we found and which makes sense as compared to what I showed you in soft tissue sarcoma earlier, that the genes that were the most expressed in responders patients were immunoglobulin genes. And immunoglobulins are produced by plasma cells, and indeed, plasma cells are higher density in responders in red here as compared to non-responders. If they are more associated to responders, as they also associated with longer survival, and plasma cells are here represented in green. You see this in the tumor core, and you see that with patients with a high density of plasma cells have a longer progression-free and a longer overall survival, and this is highly significant. Plasma cells produce immunoglobulin. Here comes the other surprise. And also to detect them, we use anti-IgG antibodies. We found that plasma cells do produce IgG, but also that IgG were present in many cases on the tumor cells themselves, suggesting that they may be produced by the plasma cells and be anti-tumor antibodies and binding tumor cells. We looked for other cells associated with longer survival and response, and we found two cells positively associated. One are activated dendritic cells, CD1CHLA-DR, high levels of these cells associated with longer progression-free and overall survival. The other were activated macrophages, again, high numbers of macrophages were associated with good survival, which seemed contradictory with what I have told you in the beginning on the dogma that in many cases macrophages are associated with poor prognosis. We found one cell that was counter-associated with response, and these were Tregs in the TLS. The other cells were in the tumor bed. These ones are in the TLS. High numbers of CD4 FOXP3 high cells are enriched in non-responders and are associated in red with smaller, shorter, progression-free and overall survival. So we try to put all of this together, and we come with a proposed mechanism. In the mature TLS, when there are not too many Tregs, in addition to activation of T cells and the help of T cells by B cells, there is also production of plasma cells that may migrate in the tumor, produce IgG antibody, maybe bind to macrophages and NK cells, induce tumor cell killing, immune complexes are taken up. Then they are performed, taken up by dendritic cells, which present them in a very efficient way, the antigens to T cells, and which may lower the threshold necessary to activate, reinvigorate the T cells when this amplification loop exists by an anti-checkpoint antibody. So how can we demonstrate that? And we try to do that also in humans. It's not so easy in renal cell cancer by analyzing the spatial organization of the microenvironment using the 10x spatial transcriptomic technique. So we ask the question, what's the distribution of various cells when there are TLS and when there are no TLS? When there are no TLS, here, as a tumor which has no TLS, we use CA9 as a tumor marker in renal cell cancer. There are almost no B cells. There are other cells, T cells, CD8, myeloid cells, etc., but they are not organized. It is a dispersed tumor microenvironment. In contrast, when there are TLS, here you see them in blue here, again, the cancer cell marker, B cells are very strongly enriched in the TLS area. T cells are enriched but found also outside. CD8 T cells, NK cells, myeloid cells, etc. are distributed, but fibroblasts are found in the TLS area, in a distance of the TLS area. So the B cells are present at TLS. Do we find various stages of the B cells? Very few naive B cells. Memory B cells are highly enriched in TLS. Germinal center B cells, by definition, are almost pathognomic of TLS. Plasma blasts really labeled TLS. Here it's really in the areas of TLS. And plasma cells producing immunoglobulins are outside, enriched in TLS and found outside. As I said, plasma cells do produce immunoglobulins. Can we detect immunoglobulin gene expression? Pan-immunoglobulin gene, IJ-kappa-C, enriched in TLS and outside. Pre-switch IgM only present in TLS. Switch IgG1 and IgA, present, enriched in TLS and found outside of TLS, suggesting that after affinity maturation, after isotypic switching, plasma cells producing IgG and IgA could migrate outside of TLS into the tumor bed. We demonstrated that in various manners, and I will show you only one example of that. We did B-cell repertoire, and this is a VH repertoire in which we analyzed families of clones. And for instance, here we found a family of 15 members, which differ, same D, same G, same V, and same CDR3 lengths, and only 15% differences in the CDR3 sequence. And so this family, if we take this blue clone here, you see that it is strongly enriched in TLS. You find it at various levels here, but you find it also at distance, several millimeters apart. Same for the green, same for the red. So showing that indeed these clones have been generated inside TLS and have migrated outside into the tumor. How do they migrate? They migrate following fibroblastic tracks. Here's the TLS, and you see at the edge of the TLS, you can detect MEM1 as a marker of plasma cells, IgG producing in IgA produce in red, IgA producing in green plasma cells. And these plasma cells are embedded in fibroblastic tracts, producing in red, producing CXCL12 in green. At distance of the TLS, here is a fibroblastic conduct, which seems empty, but it's not empty at all. Among other cells, again, there are in the collagen 1 fibers, MEM1 positive plasma cells, which are embedded with CXCL12 producing plasma fibroblasts. To demonstrate that the fibroblasts were the conduct for plasma cells, we use artificial intelligence. I'll show you here one point in which we validated by COL1 labeling for fibroblasts in red and plasma cells in white, MEM1. You see that there is a very strong contact between plasma cells and fibroblasts, most of the fibroblasts plasma cells being at less than 20 micrometers in many different experiments from the fibroblasts. But what we also noticed, using anti-IgG again to detect plasma cells, is that not only were plasma cells positive, but also tumor cells in this renal cell cancer were positive, more or less depending on the tumor. And we had both IgG and to a lesser extent IgA positive tumor cells. So to recapitulate what we found is that when there are TLS, there were more IgG positive plasma cells. When there are TLS, we find that the cancer cells are decorated by IgG antibodies. This is CA9 in green, IgG in red, and you see it is on the same cells. TLS negative tumors, they are negative, and there is a strong correlation between the presence of TLS and the number of IgG positive tumor cells and the number of IgG positive tumor cells and the presence of MEM1 positive, IgG positive plasma cells. You see here the median is at 80%. So it's quite impressive labeling of it. When IgG are present on the tumor cells, what do? They can induce killing, apoptosis of the tumor cells, as you can see here with this green dots, cleave K+3. And when we looked on the red part of what could induce this apoptosis, we found that it was probably macrophages, explaining the positive impact of macrophage. Here, for instance, you see a dying tumor cell in white. It is full of IgG around in red, and in green you have macrophages around, another one here, etc. And this has an impact on the response. We treated these patients with anti-PD-1 plus or not CTLA-4, and we separated the tumors in two parts, the ones with low numbers of IgG labeled tumor cells and with high numbers. And when there were high numbers of IgG, and this is the mean, over the mean of IgG labeled tumor cells, the response rate was 62% as compared to 18%, and the same was seen on progression-free survival. And when we added to patients treated with anti-PD-1 alone, we found exactly the same. So the conclusion for that is that TLS supplies sites in which, in addition to T cell maturation, there is B cell maturation, isotypic switch, somatic hypermutation, clonal expansion, plasma cell production. The plasma cell migrates, they produce antibodies that bind to the tumor cells. And this is associated with strong clinical response to checkpoint blockade. This is not a unique phenomenon in two tumors. And I come to the end of my talk. There has been a paper by Ziv Schulman in Cell in last March, in which he did very similar data in ovarian cancer and even detected what antigens are recognized by the antibodies. But what interested me particularly is he tested a lot of tumor cells for the presence of IgG labeling. And of course, when he comes with an anti-IgG antibody, B-cell lymphomas and leukemias are highly labeled. But among solid tumors, the most labeled were renal cell carcinoma and liposarcoma. So we were lucky, but not only. You see that in all tumor types, you find that there is a population which has antibodies on the surface and therefore could undergo the same type of mechanisms that I explained to you, and opening a new area for checkpoint inhibition, taking into account TLS and B cells in the reinvigoration. So to conclude, I propose that now we have to reconsider the organization of the immune contexture of the tumor microenvironment. Now analyzing TLS positive versus TLS negative tumors. In a TLS positive structured tumors, there is a T cell zone, a B cell zone. T cells are activated, B cells produce antibodies which reactivate the system, and you come with an anti-checkpoint and it works. In a TLS positive excluded tumor, as you can see here, the B cells are around. There are maybe some T cells inside, macrophages, but antibodies can enter into the tumor and can initiate this system. And these tumors may be sensitive to checkpoint blockade if this is taken into account properly. In TLS negative tumor, when there are T cells but not educated in TLS, they are dispersed, associated with poor prognosis, and probably not anti-tumor T cells, and of course desertic tumors have no cells at all, and these would not respond to checkpoint blockade. So what I presented to you is mostly the work of Laurent Petit-Pré, Maxime Mélan, and Etienne Besch at the co-direction of Catherine Sotes-Fridman. We collaborated for the checkpoint for sarcoma with a group of Antoine Italiano and the group of Jen Vargo and Hussein Toby at MD Anderson, for renal cell cancer with Virginie Verker, Yann Vanot, Stéphane Houdard, and many other collaborators, including Tom Chen in Taipei University. And to fully conclude, while I was analyzing these geomics, various analysis of that, I realized that there might be an anthropometric view of the tumor microenvironment. These are labeling of different subtypes of macrophages. And you see here, there is a little hidden devil that really modulates the microenvironment. Thank you for your attention.
Thank you very much, Herbert, for such a remarkable and inspiring lecture. Well, while our audience starts submitting their questions, could you give us your perspective on how helpful might be to use an immunological signature to predict outcome in hematological malignancies? Any TLS like within the hypoxic bone marrow niches where the leukemic stem cells develop? Oh, my camera is.
So these are excellent questions, in fact, and all the work that we have done and looked at the migration of the plasma cells derived for analysis that has been done on bone marrow, of course, and the CXCL12 and all the situations. So I wouldn't say that these are TLS, but I would say that they are we are in a secondary, in a primary organ, immunological organ. So, but there are similar mechanisms probably going on in taking once a response is being generated to allow this response to be protected in the niche and to circulate. As far as we are in the lymph node, call it TLS or call it SLO, whatever, yes, there clearly, I am not aware on the fact that hematological malignancies have been particularly analyzed in this respect, but there are TLS-like structures adjacent to the tumoral organization, and it is very important to localize them very closely to the tumor, because in a lymph node, it may also be a reactive lymph node to something else, and therefore the TLS may be directed to something completely different and not linked to the control. But I think that this is a completely open question. We collaborated with some hematologists to show that indeed the using MCP counter, the immune contexture that possibly controls at myeloid and lymphoid malignancies is quite similar to, or this follows similar rules than solid tumors. But most of my work has been done on solid tumors.
Thank you, interesting. And now you have many questions to go through. The first one is related to B cells. Regarding infiltrating renal tumors, have you detected cytokine secretion from these B cells in addition to IgGs?
Well, what I will answer close to it. The chemokine that is number one associated to the B cell signature is CXCL13. These are produced by T follicular helper cells and attract and activate B cells. Cytokines that promote TLS formation, lymphotoxin alpha, for instance, is also associated. In terms of cytokine production by the B cells, if this is a question, I'm not sure that this technology allows really to detect. We see immunoglobulin because it is the major production by the genes that are present there, and it overloads the system. If there is a low-level production by of certain cytokines, it's very difficult to see. However, again, while I was speaking, we found CXCL19, CCL21, so mostly chemokines organizing chemocytokine-like structures rather than cytokines themselves, which doesn't says that they are not produced, but the technology, if they are produced at a low level, we wouldn't see it.
Good. Do you think that TLS positive response resembles the formation of a tertiary lymphoid tissue?
Do I see, sorry, could you repeat?
Would you think that the TLS positive response resembles the formation of a tertiary tissue, lymphoid tissue?
Yeah, I think this is the definition of a TLS. TLS is a tertiary lymphoid tissue that takes place when, I would say, two major conditions are existing. One is antigen persistence. Second is chronic inflammation. So when these two things come together and last for a certain time, I would say the draining lymph node is overloaded, and then you see formation of these tertiary lymphoid tissues inside the vicinity of the tumors, as you see them in other organs when there are autoimmunity, inflammatory diseases, or chronic graft rejection, for instance.
Thank you. Have you tested the presence and function of neutrophils in metastatic tissues in colorectal cancer?
So we have not specifically tested that. There are neutrophils indeed in colorectal cancer. We also found them in sarcoma, for instance. There's a group of Alberto Mantovani has found that they are positively associated with better clinical outcome. We have not, they are part of the whole positive immune contexture, but I have no data on analyzing the neutrophils by themselves.
Good. Activating B cells against tumor antigen via a strong Th2 vaccine will be good? Yeah,
so I think that again, if we have this is a major question, because B cells have had for a long time a bad reputation, being associated with poor prognosis because they form antibodies forming immune complexes that activate macrophages, for instance, and produce inflammatory mediators. So it's very important to what antigen you activated. I think that what is interesting is that these B cells that we are looking at are B cells associated with production of anti-tumor antibodies in the situation I've shown you. So a strong B cell vaccine that would induce a good response to a tumor-associated antigen is certainly, we are trying various ways to induce that, but it's certainly a good way, taking also a caution on the fact that many of the antigens that have been identified for these antibodies on tumor cells are also self-antigens. So the threshold between anti-cancer and autoimmunity will be something to be considered very seriously.
Thank you, Shubha from India. What is the immune evasion strategy used by tumors in this case to counteract these plasma cells in TLS?
Well, you see that, for instance, when there are, I haven't shown you because of lack of time, I have chosen not to show you, may have seen that they have positive impact of B cells, and I have another thing that negative impact that I haven't shown you in the review. But there are different ways to counteract that. One, as I have suggested here, by the induction of Tregs. And this has been shown also in mouse models by Joshi and others. When there are Tregs which are being induced, and this may be induced by TGF-beta, by various maneuvers, this will block the maturation, and it will counteract that. And when you can get rid of them in a mouse model, you have a rejection of the tumor. There's another way, which is that the tumor cells, and we have shown that this exists in renal cell cancer, and other people have, again, the group of Mantovani has worked on it quite a lot, is to produce complement components by the tumor. So the tumor cell is usually very resistant to killing by IgG plus complement. It's a full of complement inhibitors. But at the same time, when there are a lot of complement components are being produced, this has an impact on angiogenesis, entertains inflammation, activates macrophages, and even in the presence of IgG, can counteract the positive impact of IgG, for instance.
Is there any treatment to promote the formation of TLS?
Yeah, so there are simple treatments, and I have no time to show you. Immunotherapy. If you treat patients by anti-checkpoint inhibitors, and you can follow them, this is the work Jen Vargo in the Nature paper shows that very clearly, that not only is TLS predictive of response, but the induction of TLS by immunotherapy is even more predictive of the positive impact of immunotherapy. For instance, Michele Maio works on approaches of demethylation, epigenetics, that increases the number of antigens and inflammation together with a checkpoint blocker. Radiation therapy is a good way to induce TLS. But there are more specific ways. People have used light, for instance, lymphotoxin alpha, CXCL13, CCL19, CCL21. There is a large array of work in experimental models to try to do that. The big problems, there are two problems with that. One is that it's very difficult to have experimental models for TLS in mice because tumors in models in mice are very aggressive. And therefore, as I told you, you need a long chronic inflammation, and you can get them in oncogene-driven tumors, for instance. And secondly, one has to bring the activator on the place of the tumor. You don't want to induce lymphoid organs everywhere in the body to make anti-self antibodies. But these are ways that are being used. But one of the, also there's a nice work by Connie Trimble in which she used GVAX together with a vaccination to HPV E6, E7, and only in patients in which there is TLS formation after the vaccine respond by producing a response and survive longer after treatment with the vaccine. So various ways that modulate the immune microenvironment by releasing antibodies and increasing inflammation will induce TLS.
Yeah, related to this, did you check the PD-1 expression in these TLS B cells? Do you think the checkpoint inhibitor therapy can have a direct effect?
So this is a very important point. When you look at PD-1 expression, the number one cell in the TLS that express PD-1 is the T follicular helper cell. You can almost use if you make if you take CD3 PD-1 as a marker, you beautifully label your crown of T follicular helper cells around the B cells. But there are B cells that express PD-1 as well. And this is a completely open way. For the moment, I have not seen any real indication that if and how an anti-PD-1 treatment modulates these B cells in a way positively or negatively. But again, it's a little complicated because they are not the most expressing PD-1 cells that one finds into a TLS.
What about regulatory B cells?
So again, I can look, maybe I shouldn't answer this way, I can look at cells which have a very easy way to characterize them by immunoimaging. So it's very difficult for me to see, to know, oh, I could detect with great certainty a regulatory B cell. I am attracted by the context, by the concept. If T regulatory T cells impact TLS and impact response, and so B regulatory regulatory B cells, if they produce the same type of cytokines, IL-10, IL-35, etc., should also have them. However, I personally, and if somebody wants to send me a note, I don't know what is the consensus marker that I can use to identify these BRAFs.
Good, thank you. Would it clinically recommended to not administer any immunosuppressants or immunomodulatory drug products to these patients?
You know, we are at the beginning of a new era. I think it's Dr. Selina who has shown that corticosteroids down-regulates TLS. Since the work of the people working with microbiomes, we know that antibiotics is not such a good idea to administer. So we are in a situation in which, again, there is a fine balance to find, both in terms of timing and in terms of dosing. In terms of timing, maybe immunosuppressive drugs can be highly necessary to treat a cancer at a given moment. But of course, it could hurt the production of TLS and of the immune reaction in general in the TME. But this reconstitutes. Okay. So if it is dosed at a time which is at distance when you come with checkpoint blocker, maybe it is not such a problem. The other point is, if you have a strong immune reaction going on, when you activate it even more with anti-immunotherapy, you have anti-autoimmunity that takes place. So maybe then you will have to use anti-immunosuppressive drugs to counteract that. So really, I think that what are the principles and how to use these different approaches, antibiotics, immunosuppressive drugs, etc., has to be taken now in consideration of the new knowledge of what is the immune reaction in the immune tumor microenvironment.
In absence of any anti-tumor treatment, is it possible that these TLS are at some point beneficial for tumor homeostasis?
I think that they are above everything prognostic factors. I think that they control tumors and what is interesting is that they control the tumors different. We find TLS in primary tumors, but also in metastatic tumors, for instance. So I think that a reaction takes place, and this reaction controls the tumor. We know that if nothing is done, after a while, tumor will win. So they participate in what I think properly Bob Schreiber calls the equilibrium phase. They control the tumor. Maybe at the very beginning they help to eradicate the tumor, but after a while, if you do nothing, the tumor will win, and some therapy will have to be done. But what I think is very important is that what has happened before the major tumor treatment, which is surgery, before the surgeon comes to take the tumor out, the tumor has interacted with the immune system of the patient for years sometimes. And TLS have been a school in which the immune system has learned to interact with this tumor. Then the surgeon takes it out, but T cells, memory B cells, that had left these structures have been somewhere in the bone marrow or whatever, sleeping there. So therefore, if years later a metastasis comes, they can be reactivated and reinvigorated, maybe with checkpoint blockers to control that.
Thank you. Maybe our last question is how the inflammation status, I mean, morbid preconditions, can influence the TLS shape and the clinical outcome.
So it's all a balance, and we know that to have mature TLS, but again, for instance, if you take a liver with a preclinical stage of pre-tumoral stage, with pre-cancerous stages of hepatocellular carcinoma, this plastic nodules, thing like that. Inflammation is very strong, and TLS are mostly immature. There are not enough antigens, it's not a mutated tumor, and therefore inflammation pushes TLS formation by itself, but there is, my interpretation is that there are no real target for them, and these TLS remain in an immature form. They do not undergo full maturation, and they rather help the cancer to evolve, and they do not control the tumor. When the cancer is present, when antigens are being produced locally, may be amplified by the beginning of the reactions to antibodies and things like that, now you have mature TLS, even if the inflammation is being present, and you can modulate the equilibrium in favor of the response. But it is a disequilibrium rather than an equilibrium, and inflammation will have both positive and negative impact on the history of the TLS.
Thank you. Unfortunately, our time is over. Thanks again for such an extraordinary lecture, Hervé, and the audience for their feedback. Please stay safe and see you in Cape Town 2023. Mark your calendars.
Thank you very much for having listened to me and for all the questions. So if people want to send me questions through mail, feel free, of course.
Thank you.
Bye-bye.
Good day, good night.